Thank you for this opportunity to be here. It is my honor. My name is Eric Wagner. I'm at Emory University in Atlanta, Georgia. I'm going to be talking about managing the infected arthroplasty with different options, as well as how to actually diagnose this. If I should disclose anything, I'm a product of my mentors, both here and abroad. One of the interesting things, and one of the things that's really evolved, is all the different types of microbial flora that you're going to see in the shoulder. C. acnes is the one that you most commonly are referenced to, but there's multiple other organisms that you're going to have to deal with. And it's important to recognize the organisms as you treat them differently depending on their sensitivities and specificities and how they are how they're resistant to potential oral antibiotics. So an acute periprosthetic joint infection is going to be the first thing we talk about. And my definition is these are less than 6 weeks from the primary total shoulder or less than 3 weeks from the symptom onset. Antibiotics alone don't tend to work for these, as there's a relatively high rate of failure, has 60% in this study. But when antibiotics with surgery is a reasonable approach, as in this preliminary study showing 10 patients with an acute PGI, you had a 70% success rate by retaining the components and just doing an IND plus antibiotics. And actually, chronic PGI, that's a little bit different story. So chronic PGI, just an IND and retention does not really work, as it has a very high overall failure rate. For these chronic PGIs, and once again, my definition for chronic PGI is greater than 6 weeks from the primary total shoulder or greater than 3 weeks from symptom onset. The way you diagnose chronic PGI, at least the way I like to diagnose it, is there's multiple different things that you can take into account. ESR CRP, alpha-interventin, synovial white blood cell count, synovial CRP, and cultures. And really, for me, cultures is the ultimate way to diagnose this naturally. This is a nice sort of review that kind of demonstrates different options on how to actually do this. Aspiration is really not so helpful. It's only helpful if it's positive, and even then you don't even know how to interpret the results in all the cases. But arthroscopic biopsy is quite helpful, particularly if you can get some sort of positive result. And if you get a negative result, you can be relatively confident that this is not likely an actual infection. So ultimately, my goal is you get 2 cultures of the same organism prior to entering the OR to help guide treatment. So how do you treat these PGIs once you've actually diagnosed it? Well, in a chronic PGI setting, there's a single and 2-stage of reimplantation. I'm going to kind of talk to you about at least how I consider these 2 procedures. So in a single stage, it really has similar outcomes to 2-stage. And this was born in the hip and knee literature, showing us that it is possible to do a 2-stage in the setting of a chronic PGI. Other studies in the shoulder have demonstrated similar outcomes. That single stage had similar outcomes to 2 stages with the 90% success rate in this systematic review. There's multiple considerations for why you should consider the 2-stage: less virulent pathogens, potentially less complications, cost savings, the overall function of the patient. So the pathogens, for me, if this pathogen is susceptible to oral antibiotics, I do think that a single stage is very reasonable. And I do think you'll have very similar outcomes as far as curing the infection to a 2-stage. So for example, C. acnes or staph epidermidis, there's a relatively high infection-free survival rate at 5 years. And I save 2-stage for the more difficult to treat pathogens or those that are resistant to oral antibiotics. There's less complications with 2-stage. So in the less virulent organisms, when you had a similar infection eradication, you had a much lower complication rate with a single stage compared to this 2-stage. And that's kind of makes sense. And then the function naturally is going to be very good with a single stage, as basically it's equivalent of an aseptic revision when you're looking at the ultimate final functional outcomes. And finally, there's a significant cost savings, as we demonstrated that when you compare it to 2-stage, it's more than double the cost of a primary total shoulder, which is going to be much more significantly than a single stage exchange. All right, so what is my technique? Well, ultimately, it's an intraoperative aspiration. I do 5 cultures, and I do a permanent and frozen section. I then remove the implant, debride, rinse through with 6 liters of normal saline. I do like to do peroxide and dilute betadine soaks. New drapes, new gloves, new gowns for everybody. And then we will implant the new component with a vancomycin, tobramycin powder and 6 weeks of antibiotics and 3 to 6 months of oral antibiotics. So two-stage, there's certain considerations I do think it's important to consider two-stage in. So with regards to delivery of antibiotics and kind of enabling therapy, there's multiple different models, and many of these models work quite well at both maintaining the joint space as well as delivering antibiotics. In general, sometimes patients actually have high satisfaction with the spacers and choose to retain them in, as in this study at 5.6 years. In general, it's very good at infection eradication, particularly if they've already failed a prior single stage or if they're having a very difficult to treat bug. So this showed an 85% infection eradication. Other studies have showed up to 95% infection eradication. So it's very good at getting rid of these infections with the two-stage exchange. The problem is the function and the potential risk for complications, as people are often dissatisfied with the two-stage, as there is a relatively high rate of complications. And ultimately, I save this for the difficult to treat pathogens. And so that's two-stage. If you cannot treat it with an oral antibiotic, that's kind of my baseline. And some of these microorganisms are listed here: Enterococcus for rifampin-resistant Staphylococcus, quinolone-resistant gram-negative bacilli. If you have a failed prior single stage or an failed prior IND and component retention, I do think it's reasonable to do these two-stage. So my technique is I do intraoperative aspirations post cultures with a permanent section. I remove the implant and do the peroxide and betadine soaks. I'll then do the antibiotic insertion with vancomycin, tobramycin powder. 6 to 12 weeks of IV antibiotics, aspiration after a 2-week hiatus, and then I will remove the spacer, put back in the new component after doing betadine soaks and cultures. And once again, I like to put on for at least 3 weeks of antibiotics after the second stage, just to confirm that the cultures stay negative. So some considerations with this, and there's many considerations. I'm only going to touch on a few. So the reverse shoulder arthroplasty is really taking over the, as we showed in this, taking over the revision arthroplasty outcome. As in general, reverses do much better than anatomics or hemis in the revision setting. Biopsy, when you're considering biopsies or considering aspiration versus biopsy, I really think that arthroscopic or open biopsy is the gold standard in the shoulder. And this is what you should consider doing in between these two stages. So often I'll do an arthroscopic biopsy, occasionally even an open biopsy between the stages to confirm it's negative. And then ultimately, and this is sort of an interesting favorite, afterwards, or after when you look at lower reinfection rates with oral antibiotics after the two-stage change, I do think it's worth doing, especially until the cultures ultimately prove to be negative. That being said, you should consider the risk between oral and IV antibiotic, because oral antibiotics do have a much lower complication risk profile. There's certain salvage procedures you can consider: resection alone, and I consider those in the medically frail or those with really minimal bone stock, and these patients really aren't happy with resection alone. This kind of shows that in general, the functional outcomes after resection are not the best, but they do get some pain relief from it. Arthrodesis is also a consideration. And once again, I have really rare indications for this. It's really if you have no deltoid, no acromion insufficiency, and really no other real options. And this is difficult to do in the revision setting. This kind of shows the high rate of reoperations and persistent non-unions after an arthrodesis. So here's my algorithm. If an acute infection with well-fixed implants, I do an IND and component retention. In the less virulent organisms, I do a single stage with peroxide and betadine soaks, new drapes, vancomycin, tobramycin powder, and oral IV and then oral antibiotics. A two-stage exchange for those that are more virulent organisms. You can see I do like to space it with about at least 6 weeks of IV antibiotics, and then I do a biopsy after a 2-week hiatus. And then a 3-stage exchange if you've had multiple prior infections that have failed treatment. You'll do a resection plus a spacer placement, open debridement and spacer exchange, and then a reimplantation once you finally clear the infection. If you have negative preoperative cultures and aspiration and arthroscopic biopsy, this is a tough decision to make. But ultimately, if I have a low suspicion of infection, I'll do an aseptic revision, but I will treat it like a single stage exchange, and I will put it on 3 weeks of oral antibiotics. If I have a high suspicion for infection, I'll do a 2-stage exchange with time between the stages. And the time between the stages will be dependent on the type of organism. I'd like to thank you for your time, and please reach out to me if you have any questions. And thank you very much for this opportunity to give this talk.